In today's video, we're going over physical therapy rehabilitation after hip labral repair. All right, so why are we talking about post-op rehab after hip labral repair? Well, I think the big one is there's a large discrepancy in treatment protocols from different surgeons. You might have one patient that comes in after hip labral repair, and that surgeon wants no external rotation range of motion for 2 weeks. The next surgeon says, hey, limit internal rotation and flexion for 2 weeks, right? And then patient three says, my surgeon never recommended physical therapy or gave a specific protocol. So it's important that we understand why a surgeon might want to limit these ranges of motion. And obviously, we do have to ask the surgeon what they like or dislike, but it's important we understand the principles as to why they have these restrictions. The other piece is that there are surgical nuances that are going to dictate rehab recommendations. So one patient might be non-weight bearing for 2 weeks, whereas the next patient is going to be non-weight bearing for 6 weeks. And the reason being is that patient two may have had a microfracture procedure, which is going to change that weight bearing status. And we just have to respect that, because the last thing we want to do is weight bear too soon and create a hip fracture. On top of that, we want to learn what's accurate in terms of when you should be starting physical therapy, when we should be starting weight bearing, what range of motion restrictions should we be following, when should our athletes be returning to sport, and should our treatment vary based on the person or presentation. So to summarize, in today's video, we're going to go over weight bearing progressions. We're going to go over the range of motion schedule, essentially when you can start working on range of motion in different directions. We're going to go over different types of surgeries and the rehab timelines associated with each. We're going to go over a phased rehab approach, which is 4 phases. We're also going to talk about return to sport timeframes. And lastly, criteria-based progressions. My name is Dan Pope, and this is Kevin Coughlin. We are physical therapists at Champion PT and Performance. We've helped to make thousands of incredible clinicians through our online courses, communities, and mentoring programs. Kevin, you pumped for today's topic?
Yeah, Dan, this should be a good one. I know you see a lot of these at Champion. You're kind of our resident hip labral repair FAI guy. So excited to learn from you on this one. And I think any PTs out there that work with field and court sport athletes, even weightlifters, this is a pretty common surgery. So it'll be good to kind of clear the air on all the different rehab protocols that you were talking about, because it is kind of the Wild West. You see a little bit of everything from different surgeons. So kind of cool to see what the research says.
Yeah, and you've seen a lot of these too. We have like good relationship with a couple hip doctors, and I feel like you've been seeing a lot of these FAI patients as well. So I'm curious what you think of the rehab protocols that we're going to be talking about. I think we're going to have a lot to say, and a little spoiler alert, but we're kind of in the dark ages in terms of rehab, trying to figure out what's appropriate for these folks. But yeah, we'll hopefully get some good information for the listeners. All right, so in today's video, we're mostly going over one paper. This paper is entitled Post-Operative Rehabilitation for Arthroscopic Management of Femoral Acetabular Impingement Syndrome, Contemporary Review. And essentially, it was a review paper of a bunch of other papers. They're looking at post-op rehabilitation. And I did find myself going back into those papers pretty frequently to see the specifics of what they're talking about. And if you're interested at reading the post-op protocols, most of these studies do have protocols associated with them. And then I'll leave a link to the references in the description. You guys can check that out. But let's get going. I'm excited here. All right, so first I want to talk about surgical specifics. So what happens when your patient has a hip labral repair? So there are some soft tissues involved. Essentially, when you have this surgery, you have portal holes placed through the front side of the hip, and you can either have that labrum debrided, so essentially they won't repair it whatsoever. They'll just take away some of the tissue that might be pathologic and creating pain. Now, this procedure really isn't done anymore just because they found that it's not as helpful as doing the actual repair. They can also repair the labrum, which is going to be most common. And lastly, they can also reconstruct the labrum. Now, I used to work in Colorado, and there were a few docs that loved the reconstruction, and they actually did with most patients. Whereas a lot of local docs in the Boston area, they just like the repair. And I think overall the repair is much more common. But the idea is that the reconstruction is performed if there's not enough viable labrum left. They'll use cadaver labrum in order to reconstruct that, right? They'll also generally perform a capsular closure after performing the FAI surgery. So essentially, when they do the surgery, they have to go through the capsule. And when they do that, they could create some instability, potentially risking dislocation. So they have to close that capsule afterwards, which is going to create some contraindications afterwards that we have to respect as physical therapists. Sometimes surgeons will do what's called a capsular plication. So if they think that the capsule is too redundant or has too much laxity, someone is presenting with microinstability, or the surgeon, while under anesthesia, just determines there's a lot of motion within the hip, they may perform a plication surgery, which is just essentially to tighten up the capsule, right? And this surgery is generally performed arthroscopically, although some surgeries are performed open. I don't see any of those anymore. Kevin, have you seen any open surgeries for these
No,
recently?
nope. I agree with you. Yep. Haven't seen those.
For sure. And the next piece is just bony involvement. So folks have FAI. It's characterized by premature contact of the femur up against the acetabulum. And in a lot of folks, they have extra bone on the femoral neck. That would be a cam morphology. And the surgery to reduce that is called a femoroplasty. So essentially, they shave down the femoral neck. And then in cases where folks have too much acetabulum or pincer morphology, what they'll do, and it's actually kind of a cool procedure, is they trim down the acetabulum. But first, they have to take the cartilage away from the joint. They trim down the bone and they kind of tack back down the cartilage on top of that. And in some patients, they actually have cartilage involvement, so some cartilage damage. And if a patient presents with cartilage damage, they may perform a microfracture procedure, which essentially they just poke a bunch of holes in the area that doesn't have as much cartilage, and then cartilage over the course of time should grow. And the microfracture procedure delays weight-bearing status, usually until about 6 weeks. And the reason being is there are case studies of folks where they'll have a fracture of the hip after early weight bearing. So one of the big differences between a microfracture and just a regular cam reduction labral repair is usually the weight bearing restrictions are a little bit longer. And usually it's about 6 weeks. And that's kind of what I've seen locally. Kevin, have you seen about the same thing? Docs tend to like that 6-week mark.
Yeah, that sounds right.
Yeah, and I have seen some local docs. We get some patients from HSS that sometimes will delay a little bit longer than, let's say, 2 weeks for weight bearing. But it just seems to be kind of surgeon's preference over the course of time. And if you're watching the YouTube video here, you can see this is actually an image of my patient. And he had some x-ray imaging prior to surgery and after surgery. And you can just see that big cam morphology prior to surgery. This patient had a pretty large alpha angle. Then after the surgery, you can see like that cam morphology just kind of scooped out as the surgeon kind of drills around the femoral neck to reduce that cam morphology.
Hey there, Broseph McJoseph. I hope you like treats. Evidence-based treats, that is. It's an evidence-based cheat sheet for diagnosing and treating femoral acetabular impingement. Now, not everybody loves searing hip pain right through the front of the hip as much as I do. And if you want to make any money as a physical therapist, you're going to have to help patients with this type of hip pain. Trouble is, got to stay up to date on this condition to know how to treat it properly. And that's where I come in. With this handy dandy little cheat sheet, we'll catch you up to date on the medical literature on femoral acetabular impingement syndrome in under 10 minutes. We go over a lot of good stuff. Definitions, prevalence, incidence, population, anatomy, risk factors, pathophysiology, mechanism of injury, clinical examination, differential diagnosis, and treatments like physical therapy, injections, and surgery. Best of all, this is a free download. I'll leave a link in the description. Go ahead and download it and get your learn on. And now back to this video.
Any thoughts on this surgical procedure before we start moving on, Kevin?
Yeah, I think that was really good. I think it's kind of interesting to hear this stuff after we did a deeper dive on the different structures in the knee, because you definitely see some parallels, right? Where debridements aren't as common as they used to be. I guess we're finding out that trying to keep the native structures intact is probably a good thing. So, like you said, that's kind of phasing out, and I haven't seen any debridements in my time practicing, but definitely a lot of labral repairs. I haven't seen a reconstruction, but it's kind of interesting. Like you said, maybe different parts of the country are doing that a little bit more if less of the labrum seems to be viable for repair. But I think those timelines that you laid out are definitely in line with what I see. Like you said, on the East Coast where we are in Boston, a lot of those docs are recommending similar things. And then a lot of the surgeons at HSS that we get seem to be on the same page as the Boston docs. So it's kind of nice that there's some continuity there.
Yeah, we'll also chat about this, but a lot of the protocols that we're going to discuss today, it's interesting because if you know the the surgical groups, different parts of the country. One of the big ones is Philippon out in Vail, Colorado. They have their own specific protocols, and they've researched a lot of them too. So you can kind of tell the local docs that like kind of learn from Philippon, or they're kind of like a Philippon doctor, right? It's just kind of interesting to see. All right. So essentially, you want a phased rehabilitation approach, meaning that you have a phase 1, 2, 3, 4, so on and so forth. I'm just going to read this quote here from the study. Despite the unanimous recommendation for a structured postoperative physical therapy program, significant heterogeneity exists among the current recommendations. A 4-phase postoperative physical therapy protocol is favored among current literature. Each phase comprised of its own goals, restrictions, precautions, and rehab techniques. The other thing I will say is that, at least in the ACL literature, and I think this is probably one of those surgeries we have the most research on, we're starting to figure out, okay, when is it appropriate to return to sport? If I return to sport 6 months, do I have more kind of re-injuries versus 9 months? If I introduce open chain knee extension at week 4, is that going to cause more laxity versus week 8, right? We're starting to learn those things. From a hip labral repair perspective, we really are not. We don't know these things quite yet. A lot of the rehab protocols are kind of all over the place, and we're not sure what's best, right? And that's kind of what we found. But today we're just going to present on what the current literature has. All right, so this 4-phase approach, phase 1 is going to be a protective phase. Phase 2 is a return to weight-bearing phase. Phase 3 is just an advancing exercise and individualizing rehab phase. And to be honest, they probably could have lumped phase 2 and phase 3 together. They're pretty similar. And then phase 4 is the return to running and return to sport phase. Let's talk about phase 1, or that protective phase. I am laughing because we have an image, if you're watching YouTube, of a guy with crutches sitting on the couch, but he looks like he has a busted nose. So he probably didn't have hip labral repair. So the image doesn't really make sense, but yeah, we're going to go with it. All right. In the protective phase, this is generally going to last from post-op day 1 to 4 to 6-ish weeks. And to be honest, we see a lot of our FAI patients post-op day 2-ish, right? Really, really fast. And I think that's particularly scary for new grads, right? And students to see a patient so fresh out of surgery. So it's really smart that we understand what to do and what not to do, right? And early on, you generally have limited weight bearing. And these studies were suggesting around a 20% foot flat weight bearing, which is preferred over toe touch weight bearing for hip flexor and calf mobility. So if I'm standing and I have my knee bent and my hip bent, and I just have my toe touching the ground, I might end up with a hip flexion contracture, or I might end up with a plantar flexion contracture. The idea is just that if I stand with my foot flat, I extend the hip, and I also dorsiflex the ankle, and that's probably good to maintain range of motion. The second piece is that if you do your foot just hanging in the air, it's actually more stress on the hip than letting about 20% of your leg onto the ground. The reason being is that you have distraction forces if you're holding your leg up. Your hip flexor is probably firing to hold your arm, or your leg up in the air. Whereas if you let a little bit of weight down, that's probably going to allow the tissues around the hip to relax somewhat. You're not putting much weight through the joint just because your foot is, 10 to 20% of your total weight, right? So that's a reason why you'll see this 20% foot flat weight bearing. In terms of general precautions you may get from your surgeon as well, is to avoid sitting for greater than 30 minutes. Avoid sitting to low seats, just because that's going to put you into greater degrees of hip flexion. Pivoting over the surgical leg, crossing your legs, as well as active straight leg raising. And the idea is, if you're going to deep hip flexion, you're just compressing the surgical surfaces that were just repaired, right? So if you just had a labrum repair and you just had a cam reduction, you're basically pressing that fresh femoroplasty up against that repaired labrum. So you're compressing those tissues together. If you do that for too long, hip might get a little bit cranky or irritated, right? The other big one here is the active straight leg raise. And I've seen a lot of different protocols over the course of time, some that are very restrictive and some not so much. But one of the problems that you'll see is that post-op patients after hip labral repair, some of them start getting this out of control inflammatory reaction in the front portion of the hip. Now, I can't say why this is, But generally speaking, most folks, when they have a hip labral repair, the large majority of hip labral repairs are in the anterior and superior part of the joint. So the top front portion of the joint where all the hip flexors lie. And if you do a lot of hip flexor exercises early on, or essentially straight leg raising, moving that leg around, utilizing those hip flexors in your ADLs and lifestyle, that can flare up the hip a lot and get to the point where it slows down your progress tremendously. And I've even heard some surgeons tell me they'd had to take the patient back in and try to debride some of that irritated tissue. Although I've never seen that personally myself, but that is just a word of caution. And we're constantly watching that hip flexor and adductor irritation throughout the course of rehab and making sure that's not kind of getting out of control. Kevin, have you heard much of that or had much experience with that with your patients?
Totally. Yeah. And I think I first heard that and learned about that from you and Dave. It's just an early caution, just being careful of loading the hip flexor too early. And I think I actually do have a patient right now who had both sides repaired, labral repairs and femoroplasties. And I didn't see him for the earliest part of his rehab because he actually had it done down at HSS, and his folks live in New Jersey. So he was down there, I think, for the first 6 weeks of rehab, and then he came up to us at Champion for the summer. And he kind of described from the onset having some anterior hip pain that sounded like hip flexor. It didn't sound like his labrum. It didn't sound like it was directly related or a direct result of the surgery. It seemed a little bit different. And as he's progressed, he's about 3 months out now. He does have a mild tendinopathy there in his hip flexor. It's reproduced with resisted hip flexion, no labral pathology. None of the labral tests seem to be positive. So, we kind of just got back. Maybe I guess he's about month 4 because we just initiated return to running. And we actually had to pull the brakes on it and kind of rehab this like a hip flexor tendinopathy now before getting back to the higher level stuff. So it is kind of a bummer. I think, we talked about it, me and the patient, for a long time. And I think it's really hard to control, especially when you have both sides done. But you just go, I think you said we don't know exactly why this happens, but you can speculate. You go from a long period where you're, not, you're barely weight bearing, you're not using your hip flexor that much. And then it's like, no matter how slow you progress, if you're not, taking count of your step count, your daily step count, which is a good trick. I know you and Dave like to use, that's something that folks don't think of. You take 2,000 or 3,000 steps in a day. That's a big jump from what you've been doing. That's a lot of reps for the hip flexor. So, we could try to speculate on what caused it, but it is a complication and it's a fairly common one. So I think going over all the precautions, like you talked about, educating the patient on those things early on, maybe sets you up for success down the road. And even little hints that you gave there, like stand with your foot flat, try not to keep the hip in that little bit of flexion with the toe touch weight bearing so frequently. Maybe that stuff sets you up for better success down the road. But this is definitely one we see as a complication and something to be on the lookout for.
Yeah. And, not to get too far ahead of ourselves, but I think one of the problems there is that we know a lot of FAI patients are weak in their hip flexors prior to surgery. And now we have to completely offload those for a period of time. And then you have to be really smart about your exercise prescription afterwards. I actually just filmed, and they will be released by the time this video is released, a bunch of exercise videos on hip flexor training, just because the hip flexors are incredibly important for FAI patients. We have to be really smart about our exercise prescription, not to aggravate folks, but to restore that strength after surgeries can be very important. And this is a personal opinion, but I think we probably miss this. I feel like as clinicians, we probably don't think about this too much. And I bet you a lot of patients go through the whole rehab process and they end up weak long-term and they never do address this. So whether or not that ends up being an issue, I'm not sure, but I do think that's probably what's going on, majority of patients. So, okay. Range of motion restrictions. So these are general guidelines, and just keep in mind this changes from study to study and protocol to protocol, but usually there's going to be some sort of hip flexion restriction. This study was saying 120 degrees for 2.5 to 3 weeks. I've seen around 90 degrees. I know a local surgeon we really like, his restriction is 90 degrees, which ends up being a bit of an issue just with ADLs and stuff. It's a little bit more challenging to manage that. Abduction around 45 degrees for 2.5 to 3 weeks. External rotation, 0 degrees for 2.5 to 3 weeks. An extension, 0 degrees for 2.5 to 3 weeks. Now, I'll also say that the external rotation limitation is pretty aggressive. And what's funny to me is that our local surgeon doesn't want to go beyond 90 degrees of flexion, right? But he allows around 30 degrees of external rotation. So you will see these funky differences and nuances from surgeon to surgeon. Now, what I think is more important is the rationale behind this, right? So why might we want to limit flexion, and particularly flexion and internal rotation, those combined movements? So when we flex and internally rotate the hip, that's what compresses the femoral head up against the acetabulum and presses on the labrum. So we want to avoid those positions early on so we don't compress those tissues that were just recently surgerized, right? Seems like a bad idea. The reason why we're trying to limit external rotation as well as abduction and extension is because when we go into those positions, it's going to stretch the anterior labrum. It's going to stretch the anterior capsule. So keep in mind, if they did a capsular closure and they did an anterior superior hip labral repair, and we go into those ranges of motion, we're stretching that repair. And we want that thing to scar down, get nice and strong, and not flare it up early on. So it makes a lot of sense. We want to try to protect those things, right? In terms of exercises and techniques that you can use, a lot of patients are going to be sent home with a CPM. So essentially, it's just something, I was able to find an image of a CPM, but it's at the knee, so it's not the right area. It's the same idea as you've ever seen a patient that has a CPM for the knee. But essentially, they lay in bed and it just bends their hip up and down passively for hours and hours all day long, which is a huge pain in the butt for the patient, but potentially can be good for reducing adhesions, which we'll talk about a little bit later. Usually these patients are kept in a hip brace for around 10 days. I want to say our local surgeon likes it to be for around 2 to 3 weeks. The papers do recommend soft tissue mobilization to the scar and the muscles around the hip. What I will say is that you're not mobilizing that scar right away. I usually wait around 4 weeks to actively mobilize that scar just to make sure it's really healed down well. I'm not opening it up, although you probably can get away with doing a little bit sooner. That's my personal preference. And you're doing soft tissue mobility or massage, the adductors, the QL, the TFL, and the psoas. I think you can make the argument that anything that's either aggravated or any range of motion that's limited, you can work those tissues to restore range of motion. One of the things at Champion that we talk about is that if you have, let's say, a hip or a shoulder or a knee, and you want to improve range of motion, but you don't want to aggravate that joint, you can work on mobilizing the tissue, which in theory can help to restore that range of motion without aggravating the joint, right? These authors did recommend trialing aquatic therapy around 2 to 3 weeks. So you have access to a pool, maybe give that a shot. We don't, unfortunately, but if you did, then maybe that would work out. And then early on, we're trying to restore range of motion. Just be cautious with these folks. Essentially, we have restrictions, and this is a personal anecdote, but I do find that a lot of these patients will naturally have their range of motion restored over time. You don't have to be aggressive pushing range of motion. I think the other piece is if you are aggressive pushing range of motion, you can flare up these patients. The other thing to keep in mind, which is funny, is that when you have a cam reduction, you'll actually restore additional flexion and internal rotation range of motion. So early on, you may find these patients are going to be a little limited because of pain, but as their pain goes down over the course of time, they'll actually have more range of motion on the surgical side compared to the non-surgical side, just because now they have reduced bony restriction within the joint, right? Early on, this study did recommend emphasizing passive range of motion into internal rotation. Just keep in mind, some docs don't like to be aggressive into internal rotation. They have restriction around 20 degrees or so. And then promoting active range of motion as much as you can. So it really depends on the surgeon. Our local surgeon allows some external rotation and internal rotation range of motion early on. So once the patient tolerates it well, we're doing active range of motion into external rotation, into horizontal abduction. So essentially things like sideline abduction, probably in a short lever to begin, working our way into clamshells, reverse clamshells within those protocol restrictions. But if you have a surgeon that doesn't like any external rotation, you're going to be very limited in terms of what you're able to do from an active range of motion perspective. You might have to really stick to isometrics early on. We're trying to restore early range of motion, and one of the requests your surgeons might have of you is something called circumduction. In circumduction, I'm gonna make a video on this. So early rehab over post-op labral repair, I'm going to do a video where I show all the strategies. So this will make a little more sense, but I'll try to describe it right now. In circumduction, you have the patient on their back and you flex their hip to around 60 to 70 degrees. And then you perform small circles. You circumduct the hip and you shoot for around 30 repetitions clockwise and then counterclockwise. And surgeons will recommend performing this 3 to 4 times a day, which is a lot. And they'll try to talk to the family members about trying to help out with this. They do this for around 2 weeks and then daily for around 10 weeks. And the reason why they do this is reduce adhesions and stiffness. And the reason why this is beneficial is because adhesions are a common cause of revision surgery. So if you're diligent about performing circumduction early on, you can reduce some adhesions and potentially have a better long-term outcome. They also recommend performing upright biking for 20 minutes, 4 to 6 days per week. For patients that don't have access to a circumductor or someone to circumduct their hip, our local surgeon does like to have them perform more bike. And I think the CPM kind of handles a lot of this as well. So it just seems like a lot of frequent passive range of motion early on is probably helpful for these folks. And a lot of surgeons will recommend prone lying for 1 or 2 hours per day. And this is just to reduce hip flexor tightness. So trying to keep some mobility within the anterior hip without overdoing it, right? From a strengthening perspective, like I said, we're already doing a little bit of active range of motion or maybe some active assist range of motion, but you can also mix in some isometrics. So things like ball squeezes for the adductors, glute sets, flexing the glutes, flexing the quads. And then, like I said previously, we're trying to work active range of motion, but sometimes we're just very limited in what we can do just because of protocol restrictions. We can also work on hip extension. We just can't go beyond 0 or work into hyperextension. But if you take a patient, have them lie on their belly with their hips hanging off the edge of the table and do a glute bridge, or basically perform a bird dog, you can work hip extension early on within protocol restrictions. You just have to be a little bit creative in your exercise prescription. And again, I'm going to do a video so I kind of show you what I like to do early on. So what are our phase 1 goals? So A, we're trying to protect that surgical repair site. We don't want to have an out of control inflammatory response in the anterior hip like we were talking about previously. Another general guideline is to try to restore around 80% of the mobility. We don't have to be aggressive here. If we are aggressive here, that can create more issues, right? Any pitfalls we may encounter are oftentimes related to that persistent inflammation. So I want to be very cautious. I ask my patients a lot of questions, how they're feeling during treatment. And I also just say before they leave treatment, see how you feel tonight, see how you feel tomorrow. And the next time I see you in PT, we'll figure out what the next steps are. So I'm constantly asking those questions throughout physical therapy just to make sure that we're not getting this out of control inflammatory response, right? In terms of criteria for progression, we basically want to see normalized gait. So working out of the crutches. Remember, this is going to be around a 4 to 6 week period. A lot of these folks are weaning out of the crutches around 2 to 3 weeks. So we're working on normalizing their gait, starting off maybe with one crutch or a cane, then working towards no crutches and just making sure they tolerate gait well and it looks normal. We also want to make sure that these folks have minimal pain. So one of the things you can do early on, if your patient is still having a bunch of pain, is to back off of your exercises. So I know that as PTs and as patients, oftentimes they just want to do more and more and more because they're excited to progress. But sometimes you have to pull back in this phase to reduce that pain so you can kind of progress along a little bit better. Any thoughts there, Kevin, before we go into phase 2?
Yeah, that's a lot of really good stuff, Dan. I think that's actionable for people. And I think you kind of hit the nail on the head with a lot of the kind of key points you made, where if we start pushing passive range of motion into, like that first resistance or especially that second resistance too early on, they're just going to not feel great. And I agree with you with the patients I've seen. I think the combination of them doing the CPM at home, the circumduction passive motion that we can do and that we can teach a family member to do is very helpful. I mean, the patient tends to really like that, and exactly what it's doing from, a biomechanical standpoint is probably tough to know, but you're probably getting a little bit of circulation of synovial fluid. You're kind of just getting the patient to not guard and just to totally let that leg relax. And that feels really good for people. And then I do think, like you said, if we start some active motion early, patients like that, they feel in control. They kind of can move their hip as much as it can move within those guidelines. And getting moving on their own tends to really help calm things down as well. And I think, like you said, working on the soft tissue mobility in PT, something that we can do, tends to help patients kind of feel better as well. When you're doing a little bit over, say, the glute or the TFL or the quad, that combination seems to help. I would just kind of second what you said and just be careful about the incisions. I think scar mobility down the road is probably important, but those first few weeks, I've seen patients be pretty tender over the incision site. So you don't really want to jam on that and risk opening up the incision or making them feel pretty uncomfortable. But I think that whole combination you laid out of, a little CPM, a little active motion, and then we assist with the circumduction, the soft tissue mobility. And a lot of times where they do have these, femoroplasty or acetabuloplasty, they tend to get their motion back, and they tend to get more motion than the other side. So you don't have to go crazy early on. It tends to kind of ease back, which is nice. And yeah, it works out pretty well.
Hey there, you little learner. Do you like this content and want to go a little deeper with that learning? You should join us with our online community, Insiders Academy. It's our premium subscription membership to help you become a better coach and clinician. We do a lot of good stuff at Insiders. We fill in those gaps in knowledge that school didn't teach you. We go over things like exercise technique and prescription, programming, periodization, strength conditioning principles, and advanced rehab. Let's get you proficient there. We also help to keep you up to date on the latest medical literature, even if you don't have time. And we do this with cheat sheets. And these are PDF downloads that catch you up to date on a given topic in under 10 minutes. And we've got a lot of them, over 50, and we're constantly updating them and adding new ones. It's pretty much the exact same thing as downloading all of our knowledge directly into your own brain. We also keep you up to date with our master courses. We cover pathologies in depth so you know exactly how to diagnose and treat patients with these issues. And we're really thorough, going over prevalence and prognosis, risk factors, anatomy, history, clinical presentation, diagnosis, differential diagnosis, patient education, and exercise prescription, as well as manual therapies. We have a whole bunch of master courses, and we're always updating and adding new ones. Some of the big dogs are rotator cuff related pain, knee osteoarthritis, shoulder instability, femoral acetabular impingement syndrome, SLAP pathology, cervical radiculopathy, lateral ankle sprains, and radicular low back pain. Who doesn't love some searing back pain going down their leg? We also include case studies with every one of our courses. This way, you can see exactly how we diagnose and treat. Each master course comes with in-depth protocols, both non-op and post-op. This way, you know the exact exercise we like to use with videos of all movements, how many sets, how many reps, how do the exercises progress over the course of time, what are the relevant manual therapies when they're indicated, and exactly what you should educate your patient about. Hey, are you a physical therapist, athletic trainer, or physical therapy assistant and looking for some CEUs? Well, we got you covered, and you can even earn CEUs for watching the content you're watching right now. Finish up the master course, take the exam, get the CEUs. Easy peasy. With Insiders Academy, you also have community access. Basically, you can have all of your questions answered by me and the rest of our team at Fitness Pain Free. This way, as you go through the learning and you have a question, you'll get it answered. Best of all, you can get started with Insiders Academy for just $1 for a week-long trial. After that, it's $25 per month. If you want to save 2 months, get them for free, then sign up for the yearly membership. I'm going to leave that link with a discount in the description below so you can check it out, and I'll see you there. Now, back to your learning. All right, phase 2. And like I said, phase 2 and phase 3 are very similar. Now, when I was reading through this paper, I was like, they probably just could have lumped it into, one phase and not confused us so much. But this is a return to weight bearing phase, which in reality, I've already returned to weight bearing. So I'm not sure why they called it that. But this essentially is going to last another 4 to 6 weeks in duration. So let's say the last phase ended at week 4 to 6. This is going to go on to somewhere between week 8 and week 12, right? And the goals here are return to full weight bearing. So ditch those crutches, which, we more or less already did. Having independence in ADLs with minimal discomfort. So just trying to get to the point where they can live their life without feeling this constantly. Building an endurance base for advanced rehab. So essentially, let's get the hip ready for more challenging movements. We want to get to the point where we can tolerate prolonged walking. We want to be able to do stairs, moderate weightlifting, and squatting without compensation.
So those are kind of the next upcoming goals in this phase. In terms of restrictions and precautions, basically everything is going to be lifted at this point. So folks are going to be weight bearing as tolerated. You're going to be able to use those hip flexors. You can do as much range of motion as tolerated well. But the other piece is you want to avoid aggravation of the hip flexors and adductors. So just because you're allowed to work the hip flexors now doesn't mean you should go ham on the hip flexors. And if you do, that could flare things up and set yourself back, right? Just keep this in mind. Another interesting thing I saw in the literature, and this is from Wahoof et al., it wasn't all the authors, it's just one of those, is that they advise against treadmill use, and they just found that it creates more anterior shear on the hip versus overground walking, which is interesting. I can't say that I use a treadmill specifically for my rehab for these patients, but it's something that you can consider if the patient's having pain walking the treadmill, maybe just see if they feel a little bit better just walking on the ground, right? Some pitfalls of this phase, kind of the same thing as last phase, just progressing too quickly. Because if you do too much, you can create some hip flexor and adductor irritation. You can also recreate the limp. And I've seen that with patients. So I'll often watch my patients at the end of the session. I'll see how they walk when they come in. Then we'll have the session. I ask a lot of questions about how they feel. And I watch them walk out. And for some patients, they actually start getting a little limpy towards the end of the session. And that's not really something that you want too much. So I just keep an eye on it. I do find with hip FAI surgery patients, the limp is a bit of a tell in terms of how fast you're going early on. And if you start to reproduce it, you might want to back off a little bit, right? The other tell is if patients are starting to lose range of motion. So we talk about this a lot, post-op ACL reconstruction. We're checking that knee range of motion every single visit. Where is it at? Is it getting stiffer? Is it getting better? And if we're getting stiffer, that's a sign we're doing too much. And the same thing goes to the hip. So if we're starting to lose hip extension, right, or hip flexion as we're progressing, that's a sign you might just be overdoing it, right? So just things to look out for from a session-to-session basis to tell if you're going too fast or too slow. And that is kind of your criteria-based progression. Are we actually displaying good movement? Are we recreating a limp? Is our range of motion staying where it should be? Is our strength improving, right? In terms of exercise and techniques, this is where we can do a lot, right? This is where we start really pushing weight-bearing exercises. Usually we're starting with bilateral movements. So starting off with, let's say, a squat or a hinge. I'm typically starting these guys off with squat and hinge variations around week 4 or 5, right? Once they can walk well without a limp, I'm introducing some squatting, some hinging, and then I introduce that for 1 or 2 weeks, and then I'm straight to unilateral movements because what we're looking for is to build symmetry between sides. So I will continue loading the squat and the deadlift throughout the entirety of the patient's protocol. It's just that I want to start hammering single-legged exercise as soon as possible. But you can't go too soon because you risk flaring up that hip. So we do closed chain, bilateral, and then progress to unilateral. You can also consider doing some graded mobilizations. And these papers actually had some cool ones, which I had never seen before. So I might end up showing those in the exercise video and manual therapy video I'll do a little bit later here. But they said to emphasize inferior and posterior mobilizations. And these can be performed with the Mulligan belt. So essentially you have the belt around the patient's hip, take them into some hip flexion while you inferiorly glide that hip joint, right? We can do an inferior glide by holding onto the foot and they're just pulling inferiorly. And they also recommended some medial and lateral glides, which are pretty interesting. There's kind of you lay in sideline, you have a foam roller that's essentially either under the hip or above the hip or one that's below the hip. And then you press to mobilize the hip either medially or laterally. And I'll do a video of that too. I never used those two specifically, but I thought they were interesting. Maybe I'll start peppering them into my patients' programs. They also recommend single-legged balance. What's funny to me is that we think so much about proprioception when it comes to like ACL reconstruction or like shoulder instability patients. And we're basically having surgery on very similar tissue in the hip. Like we go through a bunch of ligaments and repair the labrum. And those things are all super important from a proprioception standpoint. So we probably really need to think about proprioception in these patients. I think the thing that kind of pops into my mind is like, well, we haven't studied these guys for long enough yet. We have studied shoulder instability and we have studied ACL injury patients. We know that those folks need this. We've studied like lateral ankle patients. We knew those folks need this. Hip labral patients probably need this as well, right? We just haven't really studied it as thoroughly yet. In this phase, they also recommended eccentric psoas strength. I just feel like this is silly, right? I mean, like people need to work on strength. Eccentric, at least in my mind, when people say eccentric, they view that as more advanced rehab, right? So in like medical speech, it's kind of like isometrics are easy, and then isotonics are a little harder. Then eccentrics all of a sudden are really hard, right? And then you get to like plyos. What this means in my mind is that you're just advancing exercises. You don't necessarily need to include eccentrics, but that is an advancement, right? You want to continue upright stationary bike, introduce elliptical to tolerance, right? Which is kind of interesting. So at this period, they might be introducing more elliptical. And there are some accelerated programs to introduce elliptical really quick. We'll talk about that a little bit later. And then soft tissue mobility for range of motion restrictions and scar tissue mobilizations. And in this paper, they recommend at least 20 minutes of soft tissue mobility. And I've seen that in a lot of protocols, particularly from Philippon out in Vail. They just really like soft tissue mobility for these patients. And you can kind of cater the soft tissue mobility to the restriction. So if someone has limitation in hip internal rotation and flexion, then maybe you're working the posterior hip soft tissue musculature more so. They have more restriction to hip extension, maybe working those hip flexors, right? They also recommend continuing the circumduction and prone lying. Now, I'm going to give Kevin a chance to talk because that was a ton of stuff. Anything to add or any thoughts there, Kevin?
Yeah, that was good. I was just writing some things down as you went. So I think just to echo the swelling, we can't see swelling in the hip the way we can see it in the knee after ACL reconstruction. So a lot of times after we progress these new phase exercises, if it were ACL, we would monitor range of motion and swelling to see if that's appropriate. I think you had some good advice there, is looking at their gait pattern and seeing if there's any alterations in the gait. Maybe we introduce something too soon and they're walking a little worse than they were at the end of phase one. So that's something to monitor, and kind of educating the patient, like you spoke about, that 24-hour pain response. By the next day, you should be back to your baseline. You might be sore from exercise, but you shouldn't feel like you've lost motion. You shouldn't feel like you can't walk as well as you were walking yesterday. I think those are all important things just to talk about, so the patient knows what's normal to feel and what's not normal to feel. And then the other thing, like you said, getting into the bilateral movements, I think it's important to just emphasize from a PT perspective the movement quality over the quantity. Pushing the range of motion, the depth of the squat too early sometimes lends to like a shift in the hip. You can kind of see they don't want to go into as much closed chain hip flexion. So I guess ensuring they have enough hip flexion on the table. And then, if you're having trouble getting much past 90 on the table in passive range of motion, maybe you have the person start by squatting to an RX pad on a bench or 2 RX pads and reducing the motion. That seems to be pretty helpful. And then you can kind of just reduce those implements over time and they can go a little bit deeper. I know we're kind of spoiled at Champion. We have a lot of good equipment. So it's nice when we get into these bilateral movements to start out on the force decks and we can just look at their symmetry. If people have access to that, that's a great way to start. I think any lower extremity post-op, we love getting patients on there, and just it's a game for them. They can kind of see how close they can get to eccentric and concentric symmetry. But if you don't have that, I mean, there are other ways, just using the mirror or just taking videos and stuff like that. But, we're definitely spoiled to have that. And then the last thing I would just say is with the soft tissue, we kind of spoke about this in phase one, and it seems like that researcher is really advocating for this. But I would say anecdotally, my patients, again, we're spoiled. We have a lot of time with our patients. We're not trying to rush to get through things, but they do really appreciate and feel good after the soft tissue massage stuff. So, whether it's just that using these muscles, they feel restricted, they feel tight, whatever the patient thinks subjectively, it does seem to help. And it seems to be a good way to get into the session before going out into the gym. So I think all of that was really good. And it's a nice phase. They start to feel like athletes a little bit. You get out into the gym, you start doing some exercise, and it's kind of good to see the progression from phase one into this stuff.
Yeah, you did mention some good ones. I like the idea of a mirror, and a lot of these papers they'll talk about restoring neuromuscular control, and I think it's exactly what you're talking about. Particularly with hip pain patients, you'll see a shift, and this is prior to surgery and oftentimes after the surgery. They just don't like to sink into that hip, so they may shift over to the uninvolved side. They may also rotate. So they'll turn their hips a little bit just so that they're creating more space within the hip so it doesn't hurt, right? You may actually find, and it's really interesting, it's very specific to hip pain patients, but when they squat, you'll notice one side butt cheek sinks lower than the other because they can't simply sink into hip flexion well. So early on, a lot of what we're trying to control is neuromuscular control. Can we get symmetrical from side to side? And I think the mirror really helps with that. And what I will say is that the reason why patients are usually avoiding those positions is twofold, right? Could be they're stiff, right? Certainly could be that they're stiff. It also could be that they're fearful, so they don't want to go and sink into that hip, so we can cue them. But I think the other one is pain. We have to be careful about pushing people into these positions because we can just aggravate them. So I do think that early on, limiting the range of motion and then very slowly starting to reintroduce that, having a little bit of soreness, probably being okay and maybe being unavoidable. But if we push into too much of that, it can backfire on us because pain is that protective response. Usually I tell my patients that if you push through too much pain, then essentially your brain thinks that you're a psychopath. He's like, this body is trying to hurt us. We need to keep this body from hurting us. What do? We create more pain, right? So if we respect pain and slowly progress into it over the course of time, then your brain's like, oh, cool. We're fine with this. This is all right. And it kind of reduces pain. But if you push too much, the opposite occurs. So we have to be careful with those things. But really good points there, Kevin. Okay, what are criteria for advancement to the next phase? Want to see normal gait, which we already should have from phase 1. We're looking for symmetrical and painless range of motion. So at this point, we should have restored range of motion, and it shouldn't hurt, right? We're looking for no joint inflammation, irritation, or pain with daily living. We're looking for full symmetrical range of motion without pain. And we're looking for functional exercise without pain or compensation. Now, one thing I will say is a lot of post-op FAI patients will probably still have a little bit of stiffness or soreness into end range flexion and internal rotation. I think it's probably unreasonable to hold a patient into phase 2 forever just because that's still a little bit sore. If you take a patient that had FAI surgery years after their procedure, they may still be a little sore if you put them in a failure position, right? So I do think that more or less we're looking for normal range of motion that should be pretty much painless, but you may still find it's a little stiff and sore into those end ranges. So what I will say is it's kind of like swelling for a knee pain patient. We want to make sure that their swelling is like completely eliminated by the time they're jumping. But sometimes you're still battling that. Sometimes it pops up, goes down, pops up, goes down. And what I do personally is I just keep advancing these folks and I just think about that pain and make sure we're not overdoing it, right? I'm trying not to make this episode too long, but what are your thoughts on that? Because I think sometimes, Kevin, it's unreasonable. You see these like criteria for advancement and like students look at it. They're like, all right, I can't progress until this is, passed. And it's like, that's unreasonable. It's like for an Achilles repair, you need to see like, I don't know, 12 good calf raises before we progress over to, I don't know, running or something along those lines, right? I'm just making something up, but for post-op Achilles repair, like they almost never restore their full range of motion on their calf. It's not going to come back. And if you wait forever to advance those patients, they're never going to get back, right? What are your thoughts there, Kevin?
Yeah, I think you're exactly right, especially when you draw the parallel to the knee and swelling after post-op ACL. I mean, if that's the criteria to progress to, return to running, there are some patients who are 8 months out who might never start running because they still have trace or 1+ swelling. So I do think you're right with the hip as well. There are motions that sometimes remain sensitive. But I think it's a lot like the general population, right? Like if you take a lot of people and you push them into end range hip flexion or end range hip internal rotation, like the failure type test, it can be pretty painful for folks. And we know that that's not a very specific test about things going on in the hip. So I think if we're in the gym and we're just modifying exercises based on how the patient feels with actual function, then having a little pain with passive range of motion on the table might not be the end of the world. Obviously there is a time where maybe you're pushing too much and there's a new pain that wasn't really there before. But I think those terminal motions are sometimes it's unrealistic to be totally pain-free before progressing to the next thing. And sometimes we're waiting for something that might never change or might just take a really long time to change. and probably isn't going to get in the way of the next phase anyway. So I think that's important to keep in mind. Like you said, I think that's a good point, and not to be so fearful. And you don't want the patient to freak out, because sometimes if they start to feel a little bit of anterior hip pain when you're moving their hip on the table, they worry that something's wrong. This kind of feels like it did before the surgery. And then you can kind of open up a can of worms if you're always emphasizing the pain and how we have to wait for this to go away. So I think it's something we have to, keep in mind, that we don't want to lose motion. We don't want the range of motion to be painful, but we have to kind of take a step back and look at the big picture. And is this getting in the way of our progressions? And based on what based on what the patient is feeling, is it safe to progress? And I think in most cases, it probably will be safe to progress. And we just keep an eye on those things over time.
Yeah. And we're opening that can of worms a little bit too. But if you look at the outcomes after FAI surgery, it's not like you get to zero pain. I mean, I've certainly had some patients where they get to zero pain, they don't feel their hip anymore. But I would say the majority of folks still have some pain, right? And the outcomes reflect this. It's not like you have FAI surgery and essentially your pain magically disappears. That's not true at all. Majority of patients will still have some pain. It's not like your outcome measures all improve to 100% afterwards. And this is especially true for FAI surgery. So I do think that these criteria are sometimes unreasonable, because even years out, these folks don't feel 100%, right? So take it with a grain of salt. It's just not always reasonable. All right, moving on to phase 3, the individualized approach. So this is going to be 4 to 8 weeks in duration. And now the math is getting a little bit confusing. So this is going to begin somewhere around week 8 to 12 and last until somewhere between week 12 and 20. And the goals here are to be recreationally asymptomatic. So essentially, you're not returning to sport yet, but you're doing all of your activities throughout life, I guess. And it's not really painful, right? Feels fine. We're building strength and endurance. We're optimizing neuromuscular control, balance, and proprioception. So think about those aberrant motions we're talking about. So squatting down and seeing a big hip shift, right? You'll see this with things like lunges as well. When someone does a lunge, they may offload the surgical leg and put more weight on the contralateral leg, right? One interesting thing that I talk to my students about is that the compensations you see in patients that have post-op hips are going to be the opposite of what you see in post-op knees. So if I have a post-op knee that's squatting, they'll probably push their hip back to offload the knee and load the hip. If I have a patient that has a post-op hip, what they'll try to do is they'll push the knee forward to offload the hip, and they'll load the knee. The other thing you will see, and it's very odd the first time you see it, is when they go into a squat, they'll go into a posterior pelvic tilt early because they're trying not to flex from the hip, and they'll oftentimes be able to do it on one side hip. It's a very odd thing. It's this weird shifty thing where essentially they're not able to flex well from that hip. So they flex from the spine, but the contralateral hip is flexing and the spine is neutral on one side. So you see some wonky things. And your goal at this stage is just try to restore normal motion in your basic exercise as much as possible. So essentially make that squat look good, make the deadlift look good, make the lunge look good, step up should look good. All those activities should look more or less normal side to side moving forward. We also should be thinking more about restoring cardiovascular endurance and starting sport-specific progressions. We have more than enough research to show that stats like VO2 max correlate with reduced risk. If you have better fitness, you're less likely to get hurt and return to your activities. We have this in active populations like firefighters, but also in soccer players. So at least this is something I feel strongly about. We should be thinking about doing cardiovascular fitness from the very beginning of a patient's program and advancing it over the course of time, making that more sport specific as we go. In terms of restrictions and precautions, again, we're just avoiding aggravation of the hip flexors and adductors. You can always aggravate these if you progress too fast. So early on, if you introduce, let's say, a dead bug, that might flare up the hip, right? We have to back off. Later on, maybe you're doing loaded hip flexion with a cable, that flares up the hip. So essentially, we're just doing harder and harder hip flexor exercises. We have to be very good with our exercise prescription so don't aggravate patients too much. So again, asking a lot of questions about how they feel while they're doing the motion, how they're feeling the next day. Next time they come into the clinic, measure their range of motion, make sure they're progressing optimally, right? Want to make sure we're avoiding physical contact. So we're not going back and playing rugby right now. We're also avoiding high velocity movements, although we're really starting to build strength at this phase. So my thoughts are like, wow, we're building up that squat. We're building up that deadlift. We're building up the single leg exercises like lunges, single legged squats. We're getting nice and strong. We're not really doing a lot of power stuff yet, right? Wahoo Fadal, he still hates the treadmill at this phase. He recommends against it. So if you're having someone with hip pain with the treadmill, then overground might be better for them. Kuhn et al. In 2017, and essentially I'm digging into the papers that were recommended or were included in this review paper. They gave some specific timelines, which I thought were helpful. They said to avoid agility drills until week 16, which is month 4, to avoid weight-bearing hip rotational activities until week 10. So think about something like a chop where your foot is planted and we have resistance and we're rotating. He says to avoid that until about week 10. That is the mechanism of injury for FAI patients. It's generally some sort of combined hip flexion with rotation over and over again. So essentially we're avoiding that mechanism of injury for a little bit, but eventually we have to restore that strength. And they also recommend avoiding treadmill walking until about week 12, right? So if we're trying to figure out when we can start incorporating these activities, here's a little bit of guidelines there. In terms of exercise and techniques, I already said this, we're emphasizing double and single-legged strength, squats, deadlifts, lunges, step-ups, single-legged deadlifts, ramping up the load over the course of time. We introduced a treadmill walking program beginning week 12. This is interesting to me. I haven't found that walking is ever really a problem for patients. I don't understand why the treadmill would be something that's so restrictive, right? This is one of those things where you read in a research paper and it's like a head scratcher. You're like, this was an idea that makes sense, but I'm not sure if that's actually reasonable. Take that for what you will. They do recommend an anti-gravity treadmill running program in this phase, and that would be as early as week 8, right? Which can be a little quick, but we'll talk about an accelerated program in a minute. And then we're continuing range of motion and soft tissue mobility as needed. And that's essentially after measuring range of motion. So usually with my patients at this phase, I measure their range of motion. I see where they're restricted. And I only really do mobility or STM into the ranges I feel like they need it. Usually you only have an hour to work with these patients, and we have to do a lot of strengthening at this point. So you don't have a ton of time to keep them on the table doing a lot of soft tissue mobility. So I'll measure their range of motion and essentially just do whatever techniques I feel like they need, right? If they have fine hip extension range of motion, I don't feel like I need to wail on their hip flexors for 10, 15 minutes, right? So I would just start dosing your range of motion and soft tissue mobility as needed at this point, right? We're also continuing our glute activation, core stabilization, and movement prep. Pretty sure that we've debunked the idea of activation, at least in a normal population. If you have a patient that's having a hard time, let's say, activating or utilizing or feeling that they're using their glutes, maybe you can use some of those as a warm-up. But just keep in mind, I think that this term glute activation in particular is falling out of popularity, although there may still be inhibition occurring in these patients. One of the things that we do at Champion is that we will use any NMES on the glutes or even on the hip flexors early on, because if any patient does have some sort of inhibition, and this is super common in the quad post-op ACL, same thing is probably happening in the hip for FAI patients. So you can make the argument that you include some NMES or some activation exercises before you start with your training, right? That's reasonable. In terms of criteria for advancement, we're looking for pain-free full range of motion and strength. Now, you won't see the medical literature talking about how to assess hip strength the way you will see it in the ACL literature, but I do think it's a really smart idea, and I generally am testing this around week 10 to 12 just to make decisions on whether or not this person is ready for running, jumping, agility, so on and so forth. So we'll basically use a handheld dynamometer, and we'll test flexion, extension, adduction, abduction, external rotation. I will make a video on the way I like to test these things in the future, so stay tuned. But it's probably a really good idea to look at the strength for a variety of reasons. So A, criteria for advancement, we probably want to see 70 to 80% before we start doing things like running. But B, it tells you what's still weak. And I've been very surprised in the past where I'm like, whoa, your hip flexors are actually very strong, but your hip abductors are not. And if you're thinking about an activity like running, we probably need to have really strong hip abductors. And your hip abductor is not strong enough, maybe we delay things a little bit more. The second piece is that now we need to double down on hip abductor strength. So we use this as a criteria for advancement, and also we use it as a tool to figure out future programming, right? And we're also looking for no Trendelenburg. I mean, it's funny because criteria for advancement has been like solid gait every single phase. So hopefully we had phased this out by phase 3. But if not, don't progress them unless they look good when they walk.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks, because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is, if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place, so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you, and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. Second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
Kevin, any thoughts there? We just went through a lot.
Yeah, that's good. Again, I took some notes based on what you were saying, and I think it does seem like it's interesting. It's like the ACL has so much research behind it, and a lot of these other lower extremity surgeries don't have the same level of progression, objective measure progression. So I do find that I do this. I know you do this. I think we all do this at Champion, is we try to extrapolate the findings from the ACL and think that their return to sport protocols are generally pretty good. So we should probably do something similar for these other lower extremity things. So I agree with you. Like, before you start the return to run program, you should probably do a battery of strength tests and see if there's some, deficits that need to be addressed before you start a running program. So we do that. We do all the ones you had mentioned, and I'm sure you'll make, good videos on that so people can check that out. When we talk about the treadmill with that author being against it, the only thing that popped in my head, and this could be wrong, but I'm just speculating, as I know I've heard our friend Chris Johnson mention that when people run on a treadmill, their cadence is generally 5 to 10% lower than if they run outside. So I wonder if they're taking longer strides and they're just, maybe there's some shear force happening at the hip that doesn't happen at a higher cadence. So just totally speculating there. Otherwise, I don't really see how it would be so different than running outside. And then I think, this whole 4-phase progression is really nice to keep in mind, and maybe something that, people listening just take notes on, the different phases and everything you're talking about. I found recently with my post-op patients, kind of when they first come in, laying out these phases on like post-op day one or whenever they're in PT really helps them see the long-term plan. So they kind of know, why are we doing this? What does this lead to? What am I trying to achieve in this phase? I think it's really helpful. So they have a good long-term picture. And I know when it gets busy in the clinic and you have one patient after the other, you never want to be in a situation where you feel like you lose track of what you're supposed to be doing. Like, where the heck are we in this protocol, and what are we progressing to? So I think making sure that you and the patient both know, like, oh, it's week 12. Didn't you say we were going to strength test to see if I can start running? And a lot of times patients have those dates in mind because they're very excited about progressing. So I think everything you laid out there is really good, and something to talk about with the patient. So it's not just a surprise for them. They kind of prepare. And I know a lot of the patients we see, they're competitive and they get excited for strength testing. So I think having those dates on the calendar, as long as things are going well, they'll really kind of appreciate that approach, I think.
Okay, phase 4. And we could do an entire episode on advanced rehab in general, but just some broad strokes here. What are we covering in phase 4? So generally, we want to make this more individualized. This would be a bit of a return to sport phase. So essentially, we're trying to get the patient back to whatever they want to get back to, right? So that might be sport, that might not be, might just be weight training, whatever it is the patient wants to get back to. And generally, the earliest start date for this will be week 12, right? Although it could be as late as, like, I think month 5, depending on how slow they progress, right? In the Kuhn paper, this was around 16 weeks at 4 months. Basically, the goals are individualizing the program, like I talked about before, for whatever sport or activity the patient wants to get back to. At this point, we're probably introducing a return to running program. They recommend a walk jog program, which just advances over the course of time. So something like 30 seconds walk, 30 seconds jog for 15 minutes every week. Take 10 seconds off of the walk, add to the jog until you're just jogging, right? We're looking to return to unrestricted sport and activity. This is when we start incorporating some power, more endurance, agility, and plyometrics. So the new stuff is power, agility, and plyometrics. And then to establish a maintenance program after discharge. So essentially speaking, I thought this was interesting, and something I don't see in a lot of other studies, is that we want to make sure we reduce future re-injury risk, right? And we know this is super important in post-op ACL. Same thing goes for any injury. We know that your risk of having pain in the future or future injury is tied to a prior injury. Having an injury and then surgery, right, is no different. So we just need to make sure we're probably incorporating some maintenance exercises into the patient's program, maybe some additional strengthening for the backside of the hip, the lateral hip, things like lunges, chops, so on and so forth, just to keep that nice and strong. In terms of restrictions and precautions, none. But again, avoid irritation of the hip. Now, at this point, the patient's probably less irritable, but they're doing higher level activities. So now they're running, now they're jumping, now they're changing direction. The forces on the hip have never been higher, right? So despite them being less irritable, we're doing much harder exercises. So we have to be careful. And again, the same things are going to be checked every visit. How's your pain? Are you starting to limp? Are you losing range of motion? So on and so forth. Same kind of deal. In terms of exercise and techniques, here are some broad strokes. I've done a lot of videos recently, and Kevin and I are actually doing a whole course on this soon, so stay tuned for that, where we go over plyometric progressions, how to introduce and advance them. We go over running, how to introduce and advance that. Go over sprinting, so acceleration and top end sprinting. And we also go over change of direction and also neurocognitive exercise as well that have to do with agility. So if you guys are looking for more advanced rehab, I'll leave some links in the description. You guys can check that out. But in general, we're trying to advance all of these aspects and make it specific for the individual. So if I have a pitcher that I'm working with, so I've rehabbed a bunch of baseball pitchers after FAI, they have to throw really, really hard, right? And that actually involves a lot of hip rotation. But the forces on the hip are quite a bit different than, let's say, a soccer player or a basketball player, which they have a lot of hip pathology as well. But those folks have to do a lot of cutting, pivoting, changing direction, and that's where they get into hot water. So we have to train them specifically for that. I also worked a lot of Olympic weightlifters with FAI and potential hip labral repairs, and they have to get back to deep hip flexion under heavy, heavy loads. So your rehab program at this point is starting to get very tailored to whatever activity the athlete wants to get back to, right? So we're advancing functional and sport-specific exercises. They recommend exercise like box jumps, lateral cutting, scissor jumps, and single-legged squats. We're continuing soft tissue mobility and range of motion as needed, although we're probably doing a lot less of this compared to early on. And then we probably should be doing some sort of return to sport testing. And at least in this study, this was all very, very vague. And they define a return to sport test as a series of functional return to sport tests, which is funny using the same word in the description as they use for the actual word they're trying to define, where the patient is able to consistently display pain-free running, jumping, lateral agility drills, and single-legged squats, right? So return to sport testing in hip FAI patients, we don't know which tests are going to be best. There's been nothing that's really been validated, essentially saying like, hey, if you can pass these tests, you're less likely to have future revision surgeries, so on and so forth. But obviously it is smart to include some sort of return to sport testing. So Cunidol had some pretty good guidelines in terms of when to introduce sport-specific activities. So they recommended running first, starting an Alter G. If you've never heard of this before, it's a gravity eliminated treadmill where you can like run at a certain percentage of your body weight. They recommend starting this at 16 weeks if you have access to it. We're in the Boston area and we don't have an Alter G, but there are a lot of facilities that do have it. If you really want to use it, you can contact those facilities and you basically can utilize their Alter G for like a price. I know like a lot of places have like packages and stuff where you can use the Alter G. And then non-Alter G starting at 20 weeks. What I will say is that's pretty dang delayed. If patients are doing well, I'll start this around week 12, week 10 at the earliest. That's with the physician clearance for patients doing really well. I've had patients that are week 10, they're absolutely crushing it, right? And you have some that take quite a bit longer. What I will say is that 20 weeks sounds a bit delayed to me in my experience, right? In terms of agility, weeks 20 to 32 is when they were trying to introduce it and advance it. And that's somewhere between 5 to 8 months. So that's actually a long period of time, maybe too delayed. In my mind, I'd probably introduce running around 3 months and then agility closer to 4, right? Cutting, they recommend at weeks 24 through 32. I don't know how they distinguish between agility and cutting. In my mind, they're very similar, right? I'm not sure how you can perform agility exercise without cutting. So that doesn't make a ton of sense to me. They recommend plyometrics starting at week 24. I think by definition, running and agility is also a plyometric, right? So I would potentially incorporate low-level plyometrics before agility. So again, this is one of those situations where it doesn't make sense to me, right? And then return to sport-specific exercises around 24 to 32 weeks, right? Now, I don't know, Kevin. A lot of this, like if you start using your brain and think about what agility drill is, what running is, what a sport-specific drill is, it starts to not make sense, at least from this paper's perspective, right? What are your thoughts on this? Anything that clarifies some of this?
Yeah, I think like you said, I think, you and I are talking about doing a return to sport course. And I think it's because we see in papers like this and a lot of papers, there are really good guidelines for early rehab. But then when we get to the return to sport phase, there's really not. And it seems like it's very random. And I think it's hard to be good at everything. So a lot of these authors and the research groups just do a really good job with their early rehab. But I think there is a need for clarifying some of these things. So I tend to do what you said. I'll usually start with like a low level plyometric and even like an easy effort agility ladder, depending on how the person's doing. Let's say something around 3 months. And that might also start with a return to walking program. Maybe they start that a little bit earlier, but essentially we're just trying to get more and more foot contacts. And then as that month progresses, we're trying to get them at slightly higher efforts and kind of progressing those foot contacts each week. So then when we do start the return to run program, maybe around month 4 for some of the patients I've been working with, then it's something that they've already done. It's not, you don't go from not running at all to running. And then once you're running, you add in more intense stuff like, cutting or agility. And like you said, those two things are very similar. So it's hard to distinguish or what the authors mean by the different exercises. But yeah, I think that's generally a good progression. And then, we're kind of working on all things at once further down the road. It's just that we might be pulling different levers, working on one a little bit more than the other. So, once we've tolerated a continuous run type progression where we're doing some walk run intervals up to continuous running, then maybe we maintain that or build up, like you said, maybe tempo running or VO2 max efforts for return to sport. And we're also working on higher level agility around that same time. So I think that general progression of getting more and more foot contacts with plyometrics, and then easing into a walk run program, into continuous running, into more intense running, generally works well. But I think there's a need for clarifying some of these concepts out there. So, that'll be fun to work on, and hopefully we can get that going.
Yeah, you said it really well. And I think I'm just becoming a grumpy old man here and I'm being a little bit too harsh. But I do think if you're a new grad and you read this, it's going to be a little confusing. What I will say is if you delve into the studies, and I mentioned them at the end of this presentation, so stay tuned, their progressions do more or less make sense, right? I think it's just like you said, the nomenclature is a little bit off and a little bit confusing. So when you read an article like this, it leaves people a bit confused. But if you go to the original articles, it does make a little bit more sense. So probably just being a little bit harsh, getting too old. I need to check my attitude a little bit. So next we'll talk a little about return to sport testing. So there really wasn't a whole lot of information on return to sport testing. Like I said, none of this is really validated. There is something called the Vail Hip Sport Test, which the Vail has their own sports test for post-op ACLs as well. This is all out in Vail, Colorado. And I think it's kind of Dr. Philippon and the physical therapists out there have kind of created this. And I looked into this test a little bit just to see what it was. And I've personally not used this before, but essentially it's almost like an endurance test. They do single-legged squats for 3 minutes and you're going down somewhere between 30 and 60 seconds. And you have cable resistance. So you're stepping on a band and then the band is held in your hand and it's like a resisted squat for 3 minutes. And you get points for basically how long you can last and display symmetry, right? They do the same thing with lateral and diagonal bounding with a kind of band resistance. And they basically do skater jumps. They do it for 100 seconds. So it's kind of a long period of time. So it's very different than a typical like hop test for distance, right? It's more of an endurance test, really. And they do the same thing with a forward box lunge, which I had to look that up because I wasn't sure what it is, but it's exactly what it sounds like. So they basically do a lunge by stepping to a box, but they don't do the actual step up. They just take their foot up, plant it on the box, and do a lunge and press back. And they do that for 2 minutes. They also had a tuck jump test. So it is interesting. What I would like to see are more validated tests that we use currently. So why don't they look at a triple jump, single-legged broad jump? Why don't they look at a cross triple jump, vertical jump, stuff that's already been validated in other populations and start to apply that to hip FAI? That makes a lot more sense to me. It's what we tend to do, right? We are very lucky. We have force plates, so we can check for symmetry there. And essentially, we end up doing a very similar criteria-based progression, right? And return sport testing as we would for the ACL. What are your thoughts there, Kevin?
Yeah, I agree with you. I think we tend to use that equipment that we have access to. So, if it's good for the ACL, why not do it for the hip as well? So I guess what I would tend to use is probably a counter movement jump, maybe some type of squat jump or a single leg counter movement, a drop jump. It's nice to have those things. We have the 1080 as well. They can test horizontal jumping. So maybe like a single leg bound. But if you don't have those things, I guess it does make sense to do some type of, the strength testing with the dynamometer, and then maybe some of those established jumping tests that we use for the ACL. And I think with the ACL, we're looking at, are they compensating their knee dominant strategy for a hip strategy? And then we can look at the same thing when we do it for the hip. Are they using a knee dominant strategy to avoid the hip? So we could look at the quality as well as the quantity with that. But I would go with some more established tests like that, I think, and maybe it would be okay to play around with the Vail 3-minute squat test. But I think we could do better with some of these other tests that look at more sport specific things, where, I don't think in most sports you're doing something similar to a 3-minute squat, but you do those different jumps, and they give a lot of insight into power production and strength and how they do things quickly. And that seems to be the hardest thing with these lower extremity post-op rehabs, is doing things quickly. I think if things look good in a controlled setting, that's a good thing. But then when we test things on force plates, when someone has to move very quickly, a lot of times that's where we still see compensations and deficiencies and stuff. So I agree with you. I would try to look at those more tried and true tests and implement that into the return to sport testing.
All right, so almost finished up here. I wanted to talk about this accelerated protocol. It was a recent paper in 2024. And I think what's important to understand is that they didn't look at this accelerated protocol and compare it to a non-accelerated protocol to see the outcomes. Essentially, they just trialed an accelerated protocol to see if it was helpful for patients, but they weren't necessarily seeing if it was better from the standpoint of outcomes or return to sport rates, so on and so forth. Essentially, they were just seeing if this was like a viable way of rehabbing patients. And you can essentially look at the return to sport rates for this protocol and just compare it to others, but they didn't in this study, right? They just reported on the return to sport rates. But I thought was interesting is that it's quite a bit faster than what we recommended. So I don't know if we're potentially being a little too conservative, right? What I will say is if you compare post-op FAI with post-op ACL reconstruction, I would say the FAI goes a lot faster. And I've seen some patients that just progress so fast and it's a little scary and you're not sure if it's okay to push along with how well they're doing, or you need to pull back a little bit, right? However, you'll also see ACL patients do amazing, right? It's not just with FAI, and you'll also see FAI patients that kind of lag behind a lot as well. But if I had to compare, let's say meniscus or ACL reconstruction, I know they're two separate things. I think they tend to go a little slower than FAI. FAI tends to go a little faster, would be my guess. Anyway, this is Quaichin et al. 2024. Probably butchered that. Sorry, Quaichin. The population was 35 recreational athletes and 21 competitive level athletes, 10 in-demand sports and 11 in moderate demand sports. So the demand is going to indicate the level of play. So the way they partition the sports in this study was that high demand was essentially if you participated at an elite or professional level, right? And this could be soccer, hockey, field hockey, golfing, or dancing, right? But if it was a moderate demand, then you just play at a lower level. So more kind of recreational or like high school, right? So they didn't partition it by like high impact sports like soccer versus low impact like golf, right? Just so you know, which I think is probably a little bit of a problem in and of itself, because if someone's returning back to a lower demand on the hip activity, then it doesn't matter at what level, elite versus, recreational, those forces are entirely different. But either way, they had a 79% return to sport rate. 42% of those who did not return to sport cited reasons other than the hip, right? So let's say they would have had a much higher return to sport rate if folks wanted to get back to sports, right? So a lot of these folks kind of drop off, not because the rehab didn't go well, it's because they didn't feel like it or any other reason, right? And they had an average return to sport at 5.3 months, plus or minus 3.5 months. And prior research from our guy, Mike Ryman et al. In 2018 showed a return to sport of 7.0 months, plus or minus 2.6 months, right? And just going into the research a little bit more, and we're going to be doing a hip dysplasia lesson soon. I was looking at a lot of the hip dysplasia research, which contains a lot of hip labral repair within these surgical procedures with like PAO. And some of these folks are getting back somewhere between 3 and 6 months too. So what I will say is that research from Ryman is probably a little bit delayed compared to a lot of other research. So take that all with a grain of salt. This is generally an accelerated protocol. Let's delve into what they had in this protocol. So they were allowed to bike post-op day 1, which is pretty much the same as the other protocols. They were allowed full weight bearing is tolerated by 10 days, which is a little bit faster. And basically they wanted to wean off the crutches gradually until day 10. So they were allowed to be weight bearing as tolerated post-op day 1. But the goal was to wean off crutches over that period of time. So the expectation was that you throw the crutches away at day 10, right? So they're very gradually increasing that range of motion over 10 days, full weight bearing at 10 days, right? They had a 20-degree external rotation limitation, and they were not allowed hip hyperextension until week 4, but they were allowed as much hip flexion and internal rotation as they wanted. They introduced the elliptical at week 4, which is fast. In the other protocols, that was week 8. So you're getting a little bit of impact activity at week 4. They were allowed leg press and deadlifts at week 4. And they're allowed to run on the treadmill starting at week 8, right? So treadmill running at week 8. And they were progressing to intervals. So essentially doing sprints, bike sprints. And plyos were also initiated at week 8. So much, much faster than we had just mentioned. Essentially at week 12, they allowed return to sport cutting and pivoting drills. And from a return to sport criteria perspective, they're looking for hip strength within 10% of the uninvolved side, which is great to see. I think that's a really good return to sport criteria. We'd love to see it close to 100%. They isokinetically tested the quads and the hamstring, and they wanted the peak torque to be within 15% of the uninvolved. I'm not sure why 15%, not 10%. They did a single-legged hop for distance, and that had to be at least 85% of the non-involved if applicable to the patient's sport. So essentially utilizing some of those more common return sport tests. They wanted a step down test, which is essentially a unilateral squat, to be equal to the uninvolved side. So fairly robust return to sport criteria compared to some of these other studies, but very, very fast. Any thoughts on those, on that accelerated protocol, Kevin?
Yeah, that's kind of cool to see, and it reminded me a little bit of that article that we reviewed on Mike Reynolds' podcast about returning to sport for ACL in his 9 months, the magic number. And I know this study that you just talked about included some elite level athletes. And I think what we saw with that other paper was that some of the people who are getting back faster are some of those more elite level athletes, the higher level or professional level athletes. So maybe for a certain person, there is a need, or it's okay to go a little bit faster with the protocol. I think, it will be important to consult with the surgeon, maybe, depend on the surgeon. Maybe more and more surgeons will adopt this type of protocol if it does seem safe and they are hitting good criteria, right? It does seem to be a good blend of a time-based progression and criteria-based progression, especially for the return to sport. But I think it's cool to see that it is possible for some of these folks to get back around that 5-month mark, which is definitely a little bit faster. And I think a lot of athletes would like to see that because, maybe that means that's 2 more months of their season that they might be able to play compared to what some of the prior research was showing. So it'd be cool to see if more studies like that come out, and it's not really just a one study thing, but we do see with some of these higher level athletes, maybe it is realistic for them to come back sometime between maybe month 5 and month 6. So that's pretty cool.
Yeah. One of the things I will say, and these are personal anecdotes, you have to take that with a grain of salt. When I was out in Colorado, I'm not sure why, but a lot of docs we worked with, they were turning their athletes back to sport very quickly. And it wasn't just FAI, hip labral repairs, it was also ACL. We'd have some ACLs that were allowed to return back to sport 4 to 5 months, which is kind of ludicrous. You know what I mean? If they pass all their testing, then maybe you can make an argument for it, but it just seems kind of wild to allow that. And I've had some athletes that were able to return back to things like hockey because there's a lot of FAI surgery in hockey by the 4-month mark. And what I will say is that a lot of times they're not ready, and they oftentimes get more sore throughout the course of the season, and they're oftentimes picking up the pieces by the end of their season. So I would say that if they're looking great by 4 or 5 months, then maybe you can make the argument they're ready. But just my personal experience, I've had several patients now that were allowed to return back and looked pretty good, that they start getting pretty dang sore throughout the course of the season. And they probably weren't as prepared as they thought they would be. So time will tell. Obviously, we don't have a ton of research on this. It's not like they compared the 2 protocols to see outcomes, to see which was better. But, I do think that you could make the argument for getting people to return back sooner. I just get a little fearful. That's all. And one of the things I want to say is that there were 3 really good articles, I felt, in this article they went over today. Mike Voigt et al., 2010, Coons, which we mentioned a few times, 2017, and Quaitchen et al., and this was the accelerated protocol. they all contained their protocols. So if you want to check it out and see exactly what they did and or follow them, I'd recommend giving it a shot. They're all pretty comprehensive too. What I will say is that if I had to pick one, I would probably say Mike Voigt is the one that I've been influenced a lot by Mike Voigt and a few people that I guess work with his world a little bit. And I think that protocol is probably most similar to what we follow at Champion. But at the end of the day, like I said, Kevin and I are going to be making a whole course on this. I will be releasing a case study as well as a protocol myself and Fitness Pain-Free Insiders next few weeks and months too. So if you want to see exactly how we do it, you'll have access to that. All right, so now you know how to rehab post-op hip labral repairs. You might want to learn a little bit more about how to introduce return to run programs and advance those over the course of time. So you can have your athletes safely return back to sport. And well, we have just that video for you. And I'm going to leave that thing over top of Kevin's head. Go ahead and click on that, and we'll see you in that video.